for this yet another exciting session of the West Zone of the Indian Orthopaedic Association, along with the Telangana Orthopaedic Association web series on trauma. Today we have stalwarts from both the states and across many cities who will be discussing this conundrum of elbow trauma, something that has bothered orthopedic surgeons all throughout. So we will be laying threadbare the different aspects of the elbow trauma, right from the distal humeral fractures to the coronoid to the radial head. I would welcome our dignitaries who have joined us for this evening. Professor Dr. Ajit Shinde, who is the president of the West Zone of the Indian Orthopaedic Association. Professor GVS Moorthy, sir, who is the president of the Telangana Orthopaedic Association. Dr. Srinivas Kasha, who is the secretary of the Telangana Orthopaedic Association. Dr. Dhaval Desai, who is the chief of AO Trauma India. And my dear colleagues, Dr. Praveen Rao, Dr. Abhijit Vahegaonkar, and my co-coordinator for the evening, Dr. Abhijit Kare. I would invite Professor Dr. Ajit Shinde, the president of the West Zone of the Indian Orthopaedic Association, to start the proceedings. And welcome you all.
Thanks, Ashish. Good evening, everyone. Dignitaries of IOA, respected guest of honor, Dr. Prathap Kumar from Kerala, Honorary President, Shoulder Elbow Society of India, Vice President, Dr. Ram Chadda, IOA and West Zone Secretary, Dr. Naveen Thakkar, sir, and my team members of West Zone, President, Vice President, Secretary, President, Secretary of Maharashtra, Vasudev Gadegune, Dr. Narayan Karne, and Gujarat, Dr. Govind Purohit, sir, and Kamlesh Devmarari, and all the respected faculty members. Good evening and welcome to 6th webinar of West Zone. We have Telangana Orthopaedic Association with us today. I welcome President Telangana, Dr. GVS Moorthy, sir, from Hyderabad, and Dr. Secretary Srinivas Kasha, sir. He is also from Hyderabad. Thank you for your support and participation in the CME. In the past few weeks, we have had interesting topics and discussion regarding various complex injuries we come across in our day-to-day practice. Today, we are going to discuss one such an important issue, that is injuries around elbow joint. Stability of elbow joint is very peculiar, and very often these injuries land up in either instability or mostly joint stiffness. Myositis ossification is also one of the dreaded complications. We all are afraid of elbow injuries. We have excellent and prominent faculty today to discuss the issue. Dr. R Prathap Kumar, Dr. R Choudhary, Dr. Praveen Rao, Dr. Dipendra Reddy, Dr. Abhishek Vahegaonkar, and Dr. Dhaval Desai, sir, all stalwarts in the field of trauma with extensive experience in managing these difficult injuries. I congratulate and appreciate the effort of our coordinators, Dr. Ashish and Abhijit, without whom the series would not have been so successful and well managed. I thank Team Ortho TV, Dr. Ashok Sham and Neeraj Bijlani for their support. Both are here only. Thank you everyone for your patience hearing. Thank you.
Thank you very much, sir. Thank you very much. And before we begin the proceedings, Dr. Prathap Kumar, who was supposed to join us, unfortunately can't join us live online, but he has sent his lecture, and we would begin the proceedings by his welcoming us with his talk on concept of elbow instability. Dr. Prathap Kumar is the president of the Shoulder and Elbow Society of India, and we will listen to his talk before we move on to the webinar with the Telangana Orthopaedic Association.
Hi everyone. Greetings from Shoulder Elbow Society of India. I'm going to talk about the elbow instability, the concept. I'm not going into details of any surgical methods. If you look at the anatomy, you've got osseous stability and ligament stability contributing equally. However, the ligament stability is the one which is giving you more stability in the functional range of movement, which is between 20 and 120 degrees. You need to, it's very important that you need to understand the column concept and the ring concept. The column concept, you can see that there is anterior, lateral, posterior, and a medial column. Each column has got a bony component and the soft tissue components. And there are primary constraints. Three primary constraints are the ulnar-humeral articulation, which is the coronoid, the medial collateral ligament, especially the anterior bundle of ulnar collateral ligament, and the lateral ulnar collateral ligament. The brown one outside are the primary constraint, and the red ones are the secondary constraints. So this is the column concept. And if you look at the mechanism, it's not actually a pure hyperextension injury as we thought before. It is a flexion, supination, external rotation injury. As in the case of any other joint, there's a rotatory element involved here as well. And if you look at the terminology, there's a lot of terminologies here, but I will urge you to understand the three things here: posterolateral rotatory instability, which is the PLRI, the perching, which is otherwise the subluxation, and frank dislocation of the elbow joint. It's very important that you need to understand the circle of Horry, where the mechanism of injury starts and propagates, and also the pattern of injury which follows. So stage one is, there are three stages. Stage one is your lateral ulnar collateral ligament is ruptured, and that will end up in typical posterolateral rotatory instability. In stage two, along with the lateral ligament compress, you got the anterior posterior capsular tear. So that means the force of injury is traveling from lateral to medial side. And here you can get something called perching, otherwise it's a subluxation of the elbow joint. Then further, you got the stage three, the force has reached the medial side. So 3A, B, and C. In 3A, you got the posterior band of the MCL bone, and the 3B, you got the anterior band, which is the primary constraint of the elbow. So that's where you get a frank dislocation. At the 3C, you got a ripping of all the flexor pronator origin from the humeral attachment. So that is a total instability of the elbow. And sequence of repair is very important that it should follow the sequence of the injury. So it starts from the injury starts from the radial side and traverses all the way to the medial side. So you will start repairing from the lateral side. So fix or replace the radial head, repair the lateral collateral ligament, and then the ligament complex on the lateral side, and also fix the coronoid. Okay. Followed by, if it's still unstable, you'll go to the medial side and repair the medial collateral ligament or the flexor pronator mass accordingly. It's very important that this difference should be avoided. The incidence of hypertrophic ossification following dislocated elbow is nearly 45%, which I have presented this paper in the Shoulder Elbow Society, International Shoulder Elbow Society, 2010. So we usually follow a prophylactic regime of indomethacin for 6 weeks. I will just show you a few cases. So case one is a 20-year-old student who had a fall, and he ended up with a typical PLRI. You can see the PLRI here. If you can watch here, you can see the posterolateral rotatory instability. You saw that. Okay, the elbow is coming posterolaterally, and that is the surgery for that. You can see that it's completely, it's coming out of posterolaterally. And this is a 36-year-old male auto trader who had a dislocated elbow and had a repair of the radial collateral ligament, the coronoid, and the ulnar face, the medial facet of the coronoid. This is a 38-year-old female civil servant at a dislocation, had a coronoid fixation along with the lateral ligament complex. This is a 43-year-old male roofer, had a radial head replacement along with the capsule, the anterior capsule reconstruction, and the lateral collateral ligament complex. This is an anatomical radial head replacement, which is not available here. This was done in UK when I was there. And looking at the rehabilitation, we say immediate rehabilitation is very important, following a firm fixation, active gradated movement give 1 week or 10 days for the soft tissue to heal, and start with a functional elbow raise so that we can mobilize it. So take home message is a sound knowledge of anatomy and mechanics is needed, and they need a serial stabilization and a protected early range of movement. Thank you very much. All are welcome for the SSCCon 2022 in Cochin in October 28, 29, and 30th. Thank you very much. I cannot be physically there, and I hope you enjoyed it. Thank you.
Thank you very much, sir. And with that, I would like to invite Professor Dr. GVS Moorthy, who is the president of the Telangana Orthopaedic Association, to welcome everyone and take us and orient to the proceedings today. Welcome, sir.
Oh, thank you. Thank you. Respected elders and my dear friends. What I feel is very nice that this time TOSA, we are called TOSA, sir. We are not Telangana Orthopaedic Association. We are, S is also there. Telangana Orthopedic Surgeons Association. So what I felt, it is always very nice to have exchange of knowledge, particularly between two different states. How you do there, how we do here. That is, I think, is a good thing, good development for educating ourselves. And I'm very happy that our Honorable Secretary, sir, Dr. Naveen Thakkar, sir, is there with us, and Dr. Shinde, sir, is constantly coordinating it. And just now I heard Dr. Prathap, sir, and Artho TV, Dr. Ashok Sham and Neeraj Bijlani are there. And of course, Ashish and Abhijit are constantly, they are coordinating. That's very nice. There's nothing much for me to orient towards elbow, sir. They're all stalwarts are there who are going to talk. Only thing I wanted to add is, with our experience, I don't know what Shinde sir will tell. We always try to get back elbow to as normal as possible, as anatomical as possible, as functional as possible. But sometimes, in spite of all that, some stiffness will come or some instability will come. But nature does the rest. It will bring strength into stiffness and some movement, mobility into instability. That's all. I think we have to take help of nature sometimes when we fail. That's all I feel. So, nice, sir. It's a good topic. Elbow injuries, very common topic at all ages. I think we'll start our CMEs. Thank you, Ashish.
Thank you very much, sir. That's a very good sort of, punchline that you have got a strength in stiffness and mobility in instability. Excellent. I think delegates are going to sort of, ponder over that and give attention to that also. I would like to invite the secretary of the TOSA, Dr. Srinivas Kasha, and a dear friend. And we've been together in a few meetings, and I look forward to hear from you, Dr. Srinivas, on the concept of the elbow instability along with the radial head fracture.
Thank you, Ashish. So, let me just. Good evening, everyone. After a nice lecture of Dr. Prathap sir about the instability and the concepts. So now I am going to speak on the same concept of instability and radial head fracture and how it is going to contribute to the instability. How to tackle that particular situation. So let me just start with a case. 32-year-old fell from a horse and sustain this kind of an injury. The CT scan shows there is a radial head fracture, type 1, partial articular, and part of it is intact. During reduction, you can see there is a contusion on the medial side, which actually alarms about the medial collateral ligament injury, which I am going to speak in the next few slides. And the same contusion is increased 4 days post reduction when we plan for surgery. And the sequence, like Prathap sir has told, it starts from the lateral side and by radial head fixation, followed by lateral collateral ligament complex restoration and valgus stress test after that. And which, if there is a medial collateral ligament injury along with radial head, then you will have an opening on the medial side. Like in this particular picture, you can see here you got a opening on the medial side, and you have to go medially and reconstruct or repair the medial collateral ligament. In this case, the same thing was done, and valgus stress after ulnar collateral ligament reconstruction, which is not opening the joint on the medial side. So that is immediate post-op. So this particular instability is associated with radial head fracture most of the times. And the main stabilizers of elbow, like Prathap sir has clearly told, the ulno-humeral articulation, which is a bony stability, which is and the next most important primary stabilizers are anterior medial collateral ligament complex as well as lateral collateral ligament complex, which actually give rise to mediolateral stability. And at the same time, radiohumeral articulation and common flexor pronator tendon origin and common extensor tendon origin, as well as anterior capsule, give rise to the stability on the anteroposterior axis. And these are the this is the lateral collateral ligament complex. You can see annular ligament and lateral collateral ligament and lateral ulnar collateral ligament. So which is also very, very important, which actually gets attached onto the crest over the ulna, and which has to be kept in mind whenever you deal with elbow instability. And ulnar collateral ligament complex, you've got anterior bundle and posterior bundle and associated transverse ligament complex, which actually form ulnar collateral ligament. And the most important are anterior bundle and the posterior bundle, which are to be restored. Of course, the capsule, which is also equally important, and it is a secondary stabilizer of the elbow joint, and which most of the times requires repair when we are dealing with an elbow instability after you fix or after you address the UCL. The radial head fracture is the most common fracture around the elbow and usually result with a fall on an outstretched hand with or without a rotation component. So when it is associated with rotation component, which usually results in elbow instability, that is elbow goes into dislocation. So these are the associated mechanisms: shear, compression, and rotation. So in so Daniel Riley's classification, type 1 is a shear kind of a fracture, which is pure bony injury, and most of the time which all the ligaments are intact and coronoid is intact, and it can be managed most of the times with non-operative immobilization. unless there is a significant step of more than 2 to 3 centimeters, 2 to 3 mm. Type 2 is where you got a proximal radius comminuted fracture, and it is because of the intraosseous membrane rupture, that is SX lopistic kind of an injury. In this case, you have to maintain the length either by restoring the head or by radial head replacement. And type 3, which we are going to talk today, is capsuloligamentous injury, which usually associated with coronoid fracture. And it also usually a type of a shear kind of an injury associated with rotation. So with this we have already discussed. In type 2 kind of an injury, pathomechanisms are traumatic axial load through the forearm and radial head fracture associated with wrist injury, that is TFCC, can also be disrupted along with the intraosseous membrane. And here maintenance of the length is very, very important, either by fixing the radial head or by radial head replacement, so that your radial height is maintained and your intraosseous membrane goes into healing. Type 3 is dislocation along with the fracture. It is associated with rotation and axial load, and bony lateral buttress, which is a radial head, which is disrupted, and disruption of capsuloligamentous structures, medial and lateral, usually happen. And when it is associated with coronoid fracture, it is known as terrible triad. And so all the ligaments are to be addressed in this case. So let me just take you through another example. A young male for around 35 sustained an injury, fell down from a height, and you can see the CT scan, radial head fracture along with dislocation. Sorry. You can see the C-arm pictures with radial head fracture, and you can also observe medial opening, which indicates ulnar collateral ligament disruption. And here I had to use a radial head. I had to use 2 screws for the radial head to restore its congruity, along with LCL repair with suture anchors, and medially ulnar collateral ligament and anterior capsule repair, which was also done, and it is very, very important, especially when you extend the elbow. The instability is it is the main stabilizing force, and the patient is mobilized on a hinged elbow brace, and that is after a year of functional outcome, the same patient. So when it is actually a shear kind of an injury, and there is no opening on the medial side, like in this case, on valgus stress test, there is no opening on the medial side, you need not actually fix or address the ulnar collateral ligament, or it is only when there is a valgus stress which is opening, that is when you have to go ahead on medial side and repair ulnar collateral ligament. So on-table reconstruction is one of the very, very important tool, especially when it is a comminuted radial head fracture. In this case, say it is from the previous one of the cases. So it is, you can actually dislodge the head, not intentionally, whatever fragments that are there, and you can assemble them on table and reattach with a plate to the neck. So, and it gives a very good results. And so the take-home message is 3 types of radial head fractures, that is shear type, compression type, and rotation type, which is associated with elbow instability or dislocation. Decision making of radial head fracture is based on both bony and soft tissue injury assessment. Early active mobilization should be allowed to avoid elbow stiffness. Medial contusion is a helpful sign. Always check the stability after radial head fixation in the form of valgus stress. And our President Sir has nicely mentioned, nature brings strength out of stiffness and movement out of instability. That is really a punch mark for today. Thank you, one and all.
Thank you very much, Dr. Srinivas. Thank you very much. I'll just keep checking if there are any questions on the forum. In the meanwhile, I'll just like to invite Dr. Rajiv Rai Choudhary, if he is there. Or we could go to Dr. Praveen Rao while Dr. Rajiv Rai Choudhary joins in. Dr. Praveen Rao is from Hyderabad, and he's going to talk to us on an approach to a Olecranon fracture. Welcome, sir.
Thank you, Ashish. I hope I'm audible.
Yes, sir. Very well, sir.
Yeah. All right. Let me. Yeah.
Yes, sir.
So, good evening, everyone. I'd be speaking on an approach to the Olecranon fractures today. And like Dr. Prathap and Srinivas have already mentioned about the anatomy, I'll just skip through this. So we know about the primary static stabilizers, the ulnar humeral. AMCL is very important on the middle side. The lateral ulnar collateral ligament is one of the primary restraints which is there on the lateral side. So that has to be kept in mind. And then you have the secondary static stabilizers, which has already been talked about. So a little bit of surgical anatomy before we go into the topic per se pertaining to the Olecranon. So we should understand that the proximal ulna exhibits a 5 to 6 degrees of dorsal angulation. This angulation is called as the PUDA, that is a proximal ulnar dorsal angulation. It is about 5 to 6 degrees, and it is present about 5 centimeters from the tip of the palpable olecranon. So this is the PUDA, which is about 5 to 6 degrees, and this has to be kept in mind when you're actually applying a plate to this part of the anatomy. The second angulation, what is there is the 12 degrees of varus angulation. The ulna, if you look at it in the lateral view, it looks pretty straight, but when you see it in the AP plane, it has a varus angulation. And this varus angulation is about 12 degrees, which you can see on the side of your screen there. Yeah. Let's give a moment here. Apart from that, we have something called as the articular surface, which extends beyond the joint space. What does it mean? I mean, if you look at this lateral X-ray here, you will see that there's this 2 screws which are going from the olecranon to the coronoid, and they look perfectly extra-articular. The joint seems to be pretty free, but it is not so. When this specimen was taken off and dissection was done, it was found that this screw was going through the sigmoid fossa here. So what it means is that the articular surface extends far beyond what is actually seen on an X-ray. So on an X-ray, this is not the articular surface, it is something beyond this. And this was a paper which came recently by Gittins from the Harborview Center, which elucidated to this particular point. So when you see this red area here, so you have to be very careful with your screws or your tension band going into that. So if you look at this particular region here, you can see that the olecranon has been fixed with some screws there. And this particular screw is inside the joint. So you have to be careful. You have to understand that the joint surface is a little more away than what it appears on the X-ray. Yeah. A bit more of the cartilage. So you have the sigmoid notch, or so you have a bare spot in the sigmoid notch. So it is situated here. If you look at this notch, you will see that this is the coronoid part and this is the olecranon part. So you have the bare area here. It does not contain any articular cartilage. It has only fibrofatty sort of tissue here. And why is it important? Whenever you want to do an olecranon osteotomy, which is almost like an olecranon fracture, so you make sure that your osteotomy comes into the bare area. How can you plan it? So plan your osteotomy about 2.5 centimeters from the tip of the olecranon, and then you angulate it about 30 degrees. You'll probably hit the bed spot there. So this is important. The other concept is called as the Olecranon width. So if you look at this figure here, so this is your Olecranon width here. So the distance between the tip of your olecranon to the tip of the coronoid. So whenever you're reducing this, make sure that you do not distract this olecranon so that there is an instability. You also make sure that you do not over-compress it so that your olecranon width becomes decreased, which causes stiffness and probably have altered proximal radial ulnar joint biomechanics. So you need to get your olecranon width in the correct sort of dimension before the injury, what it was. The other thing is about the coronoid process. You always have to try to preserve the height. How do you know what is the height of the coronoid? It is double that of the olecranon height. So if you look at this figure here, so if this is the olecranon height, the coronoid height is almost double of that. It is 2x of that. So you have to keep that in mind whenever you're doing these cases and you see it under your CM. So you mentally make sure that you're getting the coronoid at the right height. There is one more angle which is called as the ODA, which is the olecranon diphyseal angle. So what is this angle? You take the tip of the coronoid and your tip of the olecranon and you draw a line here. You take another line which is along the long axis of your ulna. So this is the ODA angle. This has to be about 30 degrees. This is especially useful when you're reconstructing the ulna in the severe forms of olecranon fractures, like your transolecranon fracture dislocations and your posterior sort of Montagia lesions there. So this is the ODA angle. So after the bit of surgical anatomy, what is the spectrum of olecranon fractures which we actually see? I mean, this spectrum is quite a bit. If you look at the figure here, this is a very straightforward, simple olecranon fracture. Tension, failure. This is a fracture which probably your junior colleague or one of your PGs is going to operate. And the severity increases. You go into what is called as a transolecranon fracture dislocation. So this is where the trochlea is driven into your sigmoid fossa and you have a fracture here. The ulna and radius are displaced anteriorly. Most oftenly, the proximal radius and ulna are actually have a relationship. They are not dislocated. You seldom have radial head fractures and your collaterals are most of the times intact. So this is a less severe form of injury when compared to this form. What is this? This is a Beidou 2 Jupiter 2D kind of injury where you have olecranon, proximal ulna, you got your coronoid, you got your radial head, and you have a dislocation there. So there is a pattern of injuries which can range from a simple to a severe form. So all olecranon fractures are not the same. Mechanism of injury, I'll not dwell too much about it. We know about it. Classification, the commonest one is the Mayo classification. So we divided this into 3 types. Non-displaced, type 2 is displaced but stable. Type 3 was displaced with the elbow unstable. Each of them were divided into 2 subtypes. A non-comminuted and B was comminuted type. Coming to imaging, standard AP and lateral radiographs is what is necessary. Sometimes you might have to, it's a good idea to take an oblique view so that you can see the radial head in its profile so that you don't miss any of these radial fractures. CT scan, I have a very low threshold in getting a CT scan. It gives you, great understanding of the fracture, what it is, what is its pattern, what are the fragments, where are they displacing, and it helps you in your surgical planning. It is especially indicated when you have a lot of combination. You have the so-called classic intermediate fragment, which has to be elevated with a kickstand screw, or you have an antromedial coronoid facet fractures, which are difficult to identify on a plain X-ray. Example here looks like a straightforward olecranon fracture, but when you take a CT scan, you will see that there is impaction, there is an intermediate fragment there, there's a lot of combination. So CTs, I think you should have a very low threshold of having to take a CT scan. Coming to the treatment objectives, like any other articular fracture, you need to restore the articular congruity. You need to restore the joint stability. and you need this congruity and stability so that you can permit very early movement. So how do you achieve these objectives? What is the treatment strategy? The first point is to restore and reconstruct the olecranon. So here is your olecranon width, which is important. You have to restore it back. And if it is a complex fracture, you need to realign your ulnar anatomy so that you get a good ulnar length, so that your lateral column, just like Dr. Srinivas Kasha just talked about, the radial head fixation becomes easier there. So this is what we were talking about. You should always, in the complex varieties, never forget to take care of the radial head. Either you repair it or you replace it. I think in contemporary orthopedic practice, excision of the radial head has no place in these fresh injuries. And then the last but not the least, always assess your collateral ligaments, your instability, and do the repairs. Coming to treatment methods, is there a place for non-operative treatment? Yes. It is indicated in very low demand individuals who have a stable elbow with an intact extensor mechanism who are not fit for surgeries. Make sure that you follow them closely over a period of time. Don't immobilize them in flexion which is more than 90 degrees, because that is where your fracture is going to open up posteriorly. Operative treatment, all displaced fractures, all fractures which have disruption of the extensor mechanism would need an open reduction and an internal fixation, either by a tension band wire or pins or IM nails, or you could do a plate fixation. Is there any other role for excision of olecranon and triceps repair? Yes, it is done in comminuted in highly unreconstructable fractures, especially in our elderly population. Typically, these patients have loss of active elbow extension. So if the olecranon is less than 50% involved, you could actually take out all these, excise the fragments and repair the triceps onto the remaining ulna there. So now that you have decided to operate, what do you choose? How would you choose to do a tension band wiring, or would you choose to do operating? How do you come to a decision? This will help in this decision making. So you evaluate the dorsal cortex. If the cortex is intact, it's a tension band wire. If the cortex is comminuted, it's a plate. You also evaluate the fracture orientation. If it is transverse, it is tension band. If it is oblique, complex, comminuted, then it is a plate. So this is how you evaluate. A few examples. You see that this is the fracture here. It is almost transverse. The dorsal cortex is not comminuted, so a tension band wiring is probably well indicated. But if you look at this fracture, you will see that it is in multiple pieces. It is complex. There are a lot of comminution. In fact, this is also a different fragment here. So in this particular situation, a tension band wire will probably not work, and you would probably have to go with a plate fixation. So a pearl here is that as the fracture becomes more distal or oblique or comminuted, stabilization is more amenable to a plate fixation. A few examples of tension band wire. This is the same example which I showed you earlier. And this is the intra-op fluoroscopic position here. And how do you reduce it? You reduce it with an elbow in extension, take help of two pointed reduction clamps, hold the fracture well. Make sure that the hole for your circulage wire is about 4 to 5 centimeters away from your fracture, well beyond the coronae. Make sure that your transverse hole is about 5 to 6 millimeters anterior to your dorsal cortex. If you're too near to the dorsal cortex, when you're tightening the circulage wire, you might break it. So these are the precautions which you take. And this is what you get. So is there any ideal tension band wire construct? Well, yes, there are a few points which you have to take care of. Make sure that your wires are parallel, because we know that wires which are converging or diverging, they don't transmit the forces across the fracture properly. The parallel wires do, so always try to keep the wires parallel. Do you keep the wires intramedullary, or do you actually anchor it into the anterior ulnar cortex? You always try to anchor it into your ulnar cortex because it gives you stability, and the wire migration incidence is pretty low. Avoid long wires, because if you have wires which are going beyond your anterior cortex, you can actually cause impingement onto the important structures there. The anterior interosseous nerve is the one which is quite common. The wire, most often we actually wrote it just under the KYs, but it is always good that if you can to the triceps, take help of a 14 gauge needle and route your wire through that. Always have 2 knots and sequentially tighten the knots. Don't tighten the knot on one side, otherwise you get unequal compression. So you need 2 knots with sequential tightening on each side. This is the area which gives a lot of problems because this is what breaks down, this is what irritates, and this is what causes a little, extension like here. So always bend your wires 180 degrees and try to bang them into the bone. Then it becomes a little less irritable and it also gives a little bit more stability. And when you're passing the wires, make sure that you're in the center. You do not go laterally so that you violate into your proximal radial joint. Otherwise, you'll have a painful supination position. So these are certain points which you have to keep it in mind when you're doing a tension band wiring. For examples, here, this is follow up 4 months. Patient doing well. So at the end of the story, is it actually a tension band principle? Some people think it is not, because the compression does not happen when your elbow is being flexed. So your tensile forces don't get converted into compression forces when you flex it. It happens only in extension. There is a paper written, it is there on the net, you can see it. Now, coming to the plate fixation, when to use in comminuted fractures, fractures which have shaft extension, and in oblique fracture lines. What plate to use? You could use your normal plates, DCP, recon plates, 1/3 tubular plates, whatever. If you use the normal plates, make sure that you know that you have a Fuda angle there and you have a 12 degree of virus angulation. Make sure that you contour your plates so that you get a better fixation. The preferred plates are the anatomical contoured locking plates. This example is of a synthesis plate. This is a variable angle plate. You can see that these are very well contoured. Contoured plates will not fit all the anatomy. To see this, and these plates might need a little more contouring to fit into your native sort of bone which you are implanting this plate into. An example of a plate fixation. Yeah, there you can see a good nice screw which goes into your coronoid and gives you good stability. This is the AP view, and that's it. So what are the principles of plate fixation? This is the extensile posterior midline approach. It's between FCU and ECU. A learner has to be identified and you should know where it is. You don't have to isolate it off. And the olecranon fragment along with the attached tricep is reflected above to expose the elbow. So this is called as the trans olecranon approach, and this is a great approach. You can in fact tackle all the difficult variants of olecranon fracture, like your trans olecranon and your posterior Montegia types also through this. There's a brilliant paper written by David Fuller. You can see it there. So this is a picture which depicts how it actually looks. So this is your olecranon with your triceps reflected up towards the humerus, and all the important structures are actually facing you. So this maneuver is called as the shotgun exposure with hyperflexion of the elbow. So you hyperflex the elbow to about 160 to 180 degrees, and this is what you actually see. So you have the radial shaft which is staring back at you. You could reconstruct it, or you could put in a radial head procedures like Kasha had shown earlier. Your coronoid is right in front of you. You can reduce it, you can fix it with whatever is necessary there. So how does it work? This is a pictorial which depicts that. So you look through the fracture and you work through the fracture, and this is how it looks. A CM view where you can see that the radial head is delivered out of the wound and it is right in front of you. You fit the low profile. So what is the sequence of fixation? So fixation for the straightforward olecranon fractures. This is for the complex trans olecranon fracture dislocations and your posterior Montegia fixations. So how do you fix these fractures? If you know what are the components you need to fix, you will know the sequence of fixations. So these are most of the times you would see these particular fragments. These are quite constant. This is a radial head. Then you have your anterior oblique cortical fragment. This is very common in your Montegia lesions. And then you have your shaft component of your ulna there. and then you have your coronoid fracture, and then you have the Olecranon flake fragment, which has been displaced down. So the sequence, like Dr. Prathap illustrated earlier, use repair or replace starts always with the radial head. You repair it, and then you reduce including the anterior oblique cortical here. And then you reduce the coronoid process either with screws or your suture materials. And last is to fix Olecranon back onto the shaft and proceed with the definitive fixation. And last but not the least, always remember to check for MCL, LCL, and repair if it is needed. So this is the sequence of fixation. This I have taken from an article by in JOT. And here you can see first is your trial reduction with your radial head. You'll see that the ulna is nicely coming to its alignment. You can use certain instruments to hold the fixation well in the ulnar shaft. You can see here that there are two small plates which have been temporarily used to hold the shaft reduction there. And this is the time where you go after the corona. You can see two Antromedal facet has also been fixed with screws there. And this is how it looks. This is from Daphne Bean Gessner's article. This is a classic article. I think all the juniors should have a look at it. An example here. So this is a 3D CT scan. You can see the coronoid is gone. The radial head is shattered. There's the Olecranon there. The good thing is that your sublime tubercle is intact. So that means that your anterior band of the MCL is intact here. So this is what was done. Radial head processes. The coronoid was tackled with a couple of screws and the small fragment set here. But if you look at the lateral, everything seems to be all right, but your plate is off. This is what happens when because you have the triceps which is sitting here. If you're not careful, this plate is always off. So how do you prevent this? You make a small longitudinal your triceps pocket and you set this corner into it. Or there is another trick which was shared by Dr. Samir Mehta. So this is the plate which is off your Olecranon there. So what you do is that you put it onto that bone and provisionally fix it with two small KOIs. These screws are outside the plate, they're not there. And then you drill this oblique screw, so which goes from your Olecranon into your coronoid. And on tightening, you'll see that the plate has slid inferiorly and it also goes upwards, giving some compression to your Olecranon. So there's a small trick which you can use if your plate is off. Another example there, you can use this small plate to hold the comminuted segment there. This is another example of a bad posterior Montegia variant there. Radial head has been replaced. We have used two plates, one on the ulna, one on the medial, and one on the and stabilize and retain the length of the ulna there. So coming to the outcomes, does the implant matter? There's limited data. Most of it is retrospective. Union rates are almost the same between tension band and the plate. Reoperation rates are almost equal. Deep infections were more with plate and not with tension band. Superficial infections were more with tension band and none with the plate. Wound healing problems were again more with the plate at all. So what is the take-home message? Generally, Olecranon fractures require surgical treatment. In simple fractures, tension band wiring will suffice. In displaced distally based fractures, comminuted fractures, you need plating. Simple transverse fractures, current evidence demonstrates that the clinical outcomes of locked plating and tension band wiring are comparable. However, plating provides greater construct stability and fewer symptomatic hardware problems. Yeah, thank you so much. I'm sorry.
So thank you very much, Dr. Rao. I mean, it was a wonderful talk. There's so many aspects about the coronoid, about the Olecranon anatomy that I think the operating surgeon should know. I mean, it's a surgeon and a surgeon in training, and more importantly, if people know it at the beginning of their surgery, what the end result is going to be. I think that helps quite a bit. I think even the tip that you mentioned about getting the Olecranon plate, the hook just beneath the triceps. Otherwise, most of the time we see that, the AO plate has got two home run screws, say.
Yeah.
So I wanted to ask, I mean, do you ever use both the screws, or usually we get one screw which is really long and that comes to about a good 45 to 50 millimeters.
Yes.
And
I've always used one screw. I mean,
right.
I always actually break off the topmost screw there. So, I mean, I think Olecranons are not
Yeah.
made to take two of them.
Right. Right.
Yeah.
Excellent. Thank you very much. So after that, we will follow it with Dr. Jignesh Pandya's talk on who's going to talk to us about one of the ghastly Olecranon fractures around which he has treated and which has got a good take-home message. Dr. Pandya, welcome to this webinar, and over to you, sir.
Hello, am I audible?
Yes, sir. You are, sir.
Thank you very much, sir. Thanks for invitation and opportunity to be present on a webinar. Sir, I will present a bag of bones and how I will get pearls and tips and tricks to get it right. So I got few cases, and that will include some theory and more of the practical things.
Okay, sir. Sir, I think you are muted, sir. By mistake, probably you got muted. That's the reason why we can't.
Okay.
Yeah, you are unmuted now.
Yeah.
So can you start from the beginning, because we didn't. Yeah. Okay, sir.
They are all trans Olecranon Monteja fracture dislocations. So it's a variant of the Monteja fracture, but the principles of treatment are totally different. And we will see how the things. Suppose if we don't understand this injury and treat like a regular tension and wiring, then this is the outcome. So we need to understand this fracture anatomy, fracture type. We have to actually classify this fracture by understanding the fracture geometry, and then we have to plan the treatment. And if you plan the treatment in the right way, you will get the right outcome. So there are two types of dislocation. If you observe, it's an anterior fracture dislocation, one is posterior fracture dislocation. And I will tell you the peculiarity. And you can from that easily identify this is which type and how will you go. Anterior fracture dislocation means radial head is usually not fractured. So that is a big advantage. And the collateral ligaments are usually uninjured. Simple fracture. It looks grotesque and X-ray. But you know, when you evaluate this way, it's easy to treat and get a good outcome. And beware of substantial impact cell in depths of the trochlear knot. That is the key. So we have to always look for the articular impaction in the olecranon and in the base of the olecranon as well as the coronoid. This may need a structural grab sometimes to prevent anterior subluxation of the forearm. Very, very important. And the key is restoration of trochlear notch of ulna by correct alignment of coronoid and olecranon process, and metaphyseal and diaphyseal fragments can be breached with a long plate. So that is the trick of doing and understanding this fracture. Now, apex posterior fracture of the proximal ulna with posterior dislocation of radial head behind the capitulum are posterior fracture dislocation of the elbow, and these are bad fractures. Radial head is almost always fractured. So we have to do one more work to do, not only olecranon. And first priority will be that only. Lateral collateral ligament is avulsed from lateral condyle in 50% of injury. So always look for it and be ready to prepare with the suture anchor or a direct repair with the screw or a wire or whatever. The medial collateral ligament is intact unless ulnar joint is completely dislocated. So if it is not dislocated of the elbow, then this is the injury. So at the end of fixation, always check for the valgus instability. If it is there, you have to go immediately and repair medial collateral ligament. So this is how we understand. Now, restoration of trochlear notch by correct alignment of coronoid and olecranon process and operate with the bridge plating. That is the trick. See, you can see there is an example of the fracture, and it is very nicely reconstructed with a plate because radial head is intact. So it maintains the length, rotation, alignment, everything. You have to just reconstruct the olecranon and the ulna. Now, what is the sequence of repair? First, if the radial head is intact, the lateral part is okay. First is the coronoid repair. Impaction of the articular surface in the center of trochlear notch. The approach is very well showed by Dr. Rao that you flex the elbow completely more than 90 degrees and you can see everything in the front. So you repair, you go from periphery to center. So repair from anterior to posterior. So go on repairing and leave it. So once you go on reducing it, at the end of that, end of the procedure, you will have just dorsal plate to fix on the ulna. So impacts of the articular surface in the center of trochlear notch, it allows anterior subluxation, repair the Olecranon with a posterior plate. This is the sequence. With direct visualization, manipulate and automatically reduce articular fractures. Use the distal humerus as a template for reduction. Provisionally fix fragment with 1 mm K wire. Put the wires in a way that it doesn't come in the way of the plate fixation, or you can use them as a lost K wires. Reduce the proximal part of the Olecranon with pointed reduction forceps and temporarily hold the reduction with 1 or 2 K wires. Insert all K wires in a position where they do not interfere with the plant plate and screw, so you don't have to remove during the procedure. And at the end of the procedure, once you are satisfied with the fixation, you can remove the wires and you can just get your screws and plate right in the position. So this is one example. This is how you flex it and see that. This is my own case. And you can see radial head in front of your eyes. You can just hold fragment, reduce into position, put 1 or 2 mini fragment screws, and then reconstruct the Olecranon with coronoid first, then distal ulna, then proximal, like that. And you can get a plate in the right position. And you can have a fantastic outcome like this. Take from me, usually this fracture doesn't give stiffness. Distal humerus gives stiffness because extensor mechanism gets very much damaged and all the capsule and everything. But Olecranon fracture, you will usually observe that even they are a little bit under reduced or mild incongruity, they get usually good range of movement. So these injuries usually get a very nice movement. If the radial head and lateral collateral ligament is gone, then it is a different ball game. And in that case, you might get some stiffness. But if that part is intact, then Olecranon fractures usually do well. This is one more. Very badly injured. It looks very bad, but you see what radial head is intact. It is anterior dislocation. Just reduce it so you get the length. So you maintain the reduction of the radial head under the capitulum and just align all the fragments in fine and just slide your plate. I left 1 or 2 wires with the tension band with the plate and I got everything right, length, alignment, rotation, and you can see the functional outcome. Fantastic outcome at 6 months, full movement. So very bad looking fracture, but the outcomes are always good. Another one, again badly shattered, very bad injury. Commited proximal ulna, anterior dislocation of the radial head, but radial head is intact. That is very good part of this injury. With fracture lateral condyle humerus. When anterior dislocation, usually lateral condyle ligament is intact. But here, there was a lateral condyle fracture, humerus was there. So that was adding the thing. Now we'll evaluate the fracture. 3D CT with subtext of the humerus. Then I always get this view. So I get only fracture in front of me, 360 degrees. So positives are intact coronoid. See, you can see intact coronoid and anterior wall, radial head. Proximal ulna is intact. So lateral collateral ligament is intact. Negatives are very small proximal fragment. There is nothing to hold in Olecranon. Lateral condyle humerus is fracture, adding the morbidity and extensive comminution. What I did, I opened the skin, but I did not open the soft tissue. I just bridged the plate like this. All 18 fragments were aligned because radial head maintained the length. And I got perfect alignment and excellent outcome in a union in 4 and 5 months' time with excellent range of movement. So what are the factors affecting outcome in such injuries? When the radial head is there, dislocation, fracture, radial head fracture or fracture dislocation, coronal fracture and lateral collateral ligament. These are the fractures which can contribute to the bad outcome with proximal ulnar comminuted fractures. What is the template? When you reduce and fix this fracture, intact part of proximal Olecranon, coronoid fragment, radius for length and radius head fixation, and anatomical lock. If everything is done, anatomical lock plate is a template. You try to reduce everything to the plate. If it is very nicely contoured plate, and you just put it and all fragments will fall into position. So that is one more advantage of having good anatomical locking plate. So what are the pitfalls? Failure to identify and fix all fragments leads to loss of reduction and instability. So you, as far as possible, around the coronoid and Olecranon, do fragment specific. Distal to coronoid, you can bridge the plate. But that is very important. Anterior wall and coronoid needs proper fixation. Non-anatomic reduction will lead to radial head subluxation, bony impingement, and restricted range of movement. Here you can see the circle and arrows, which has not reduced this anterior ulna and the Olecranon properly. I revised this case to a, then again and could get very nice reduction. Poorly placed hardware, screws or pins lead to ulnar nerve irritation, restricted range of movement, and articular degeneration. So what are the pulse? Again, this you can see the outcome. Fantastic outcome in this injury. Full movement. Pre-op planning, stable fixation of all the fragments, simple fracture due to tension wiring or a plate, complex fracture, plate and screws. Coronal process from posterior, medial or lateral, what are the approach available? I mean, radial head is fractured, then you can do lateral, medial, both. But if radial head is intact, then you can have to go from through the fracture. Radial head from the lateral or posterior, fixed periphery to center and distal to proximal in ulna. Intrafluoroscopy is very, very important and mandatory to check your reduction and position of the screws and test the elbow through full range of movement for stability, range and congruence at the end of the procedure. Full flexion, full extension should be possible without any impingement. That is the method and message. So I cannot teach anybody anything. I can just make them think. Thank you very much.
Thank you very much, Dr. Pandya. Excellent series and amazing work, which a lot of people won't see. I mean, such a collection of ghastly Olecranon and comminuted fractures. Amazing. I think in the last two talks, we have just gone from a pre-basic level to an absolute master's level in term of spectrum of injuries. Thank you very much, sir.
Thank you very much, sir. So kind of you. So kind of you for the words.
Thank you. And having heard that, I think we'll move to the other end of the elbow, the distal humeral end. And I would like to invite our dear friend from Pune, Dr. Abhijit Wahegaonkar. He's going to talk to us on distal humeral fractures. Welcome, Abhijit.
Thank you. Thank you so much, Ashish. Disclaimer, I am in Jaipur today, so not in Pune actually. Just give me one brief moment and I will pull up my talk.
I think it's an amazing collection of fractures that that we have seen in the last three talks, isn't it? Right from Dr. Srinivas's talk on stability to Dr. Rao and Dr. Pandya. I think this webinar just gets interesting. I was talking to a lot of students and our residents, asking them to have a look through this webinar to understand the basics. But I think they are getting a much more than basics sort of insight into these fractures. It will just highlight the importance of looking at these injuries very carefully.
May I start?
Yes, sir. Yeah, Abhijit. Yeah.
Thank you so much, Ashish. So good evening, everyone. The office of the TOSA, as well as the IOA West Zone, thank you for the opportunity to be here with you all. My task is to talk about 360 degrees humerus fracture. And this is going to be a little bit of theoretical talk, and then Deepthi will come in with some clinical examples and case series. I would like to begin this talk with this short case. This is a 38-year-old right-hand dominant intensivist who fell from a flight of stairs and injured his left elbow, was initially treated by close reduction in a slab. And this was his initial x-rays. And that was the lateral x-ray. He was referred to us by an orthopod colleague, and he presented to us approximately 10 days after the injury. The swelling had reduced, there was some ecchymosis and bruising, and the skin condition was otherwise okay, no distal neurovascular complication. This was a CT scan that he came with. We were not able to make much of it, so we got some CT scan done, and just like we saw some very nice reconstructions earlier on, we got a good CT scan with this. There were also some digital subtraction views, as you can see here, where we digitally subtracted the ulna and the radius to give us more information as to what was actually broken. And you'll perhaps appreciate that it's a very low fracture, and the fracture is present in all planes, in the transverse, as well as the sagittal plane. And at this juncture, we were wondering what are the challenges that we are looking at, what approach would we use, what are the implants that we should have on the back table, and what would the post-op rehabilitation be like. And I think for distal radius fractures of distal humerus fractures, this should be the way to kind of go, think ahead in time. So we decided to go ahead with a posterior approach, and with an osteotomy of the olecranon, which is a standard approach. We've fix the anterior spindle first, and then the lateral column. And we noticed at this point in time that the medial column was severely comminuted, it was a very low fracture, where the distal purchase was impossible with the medial column pre-contour plate. And at that point in time, what was a bailout? So we kind of used headless compression screws along with a tension band wiring, kind of an improvisation, and that's how we got our purchase. And this was quite stable because when we carried the elbow through a range of movement, we found that the construct was quite stable, and we were quite encouraged to start early range of movement. Anterior subcutaneous transposition of the ulnar nerve was performed with meticulous hemostasis and a closure over drain in layers. At around 3 months, the fracture went on to unite, and these were his outcomes at around 3 months post-operatively. So with that brief introduction to the challenges that we see and face in the management of distal humerus fractures, what are the challenges that we face? One is that this is a very complex anatomy with a unique articular surface, more so with reference to the anterior spindle, the capitulum, and the trochlea. There is very little cancellous bone between two very strong columns. They account for about 33% of humerus fractures and about 2% of all fractures. Again, the anatomy is not alien to any of us, but suffice it to say that the humerus, the distal end of the humerus, is a very peculiar anatomical part with the angulations making up for the challenge when we are reconstructing, especially comminuted fractures. So the extra-articular or intra-articular part of the distal humerus has been the subject of classifications, and we have several classifications out there. I won't belabor too much on this, but suffice it to say that, so we also have the AO classification, the OTA classification, again, something that is out there for all of us to refer to. We won't belabor too much on that. However, the goals of the treatment for whatever type of fracture that we encounter remain uniformly standard. One is to accomplish an anatomic restoration of the articular surface, restoration of the geometry especially, and then stable fixation to allow early range of movement. And the treatment options, again, for any other fracture, range from closed reduction and casting to a complex open reduction internal fixation, X-fix, and then these variants which are included for historical kind of an interest. And the bag of bones was also one of the methods. We no longer use it. External fixation has been described in literature. It still holds true, especially with the advent of compass fixators, but the standard of treatment perhaps remains open reduction and internal fixation. And we've all gone through these evolutions, right from using screws to reconstruction plates with different designs, and then we have the pre-contour plates or the anatomical plates that are available now. The biomechanics of the distal humerus, again, are and the fixation have been studied, and there are certain standards that have now been described in literature based upon the different constructs. And we could either use a parallel plating or a 1990 plating to increase the strength of the construct. The techniques that don't work are perhaps also more important to understand rather than techniques that work, because we every now and then see such problems wherein there is a disaster waiting to happen or has already happened. There are, again, standard approaches such as the Brian Morey triceps reflection technique, the transtricipital approach as was described by Frederick Schwend. We have the Olecranon osteotomy and the triceps reflecting Anthony's pedicle, the trap approach. Again, this is something which is a very popular and a very commonly used approach. However, we need to be careful about the complications that might be associated with the Olecranon osteotomy. The trap approach is an interesting approach, wherein we use approximately 15 centimeter long posterior incision, wherein we identify the ulnar nerve, and then we raise a flap of the triceps along with calcaneus using sharp dissection so as to reflect the entire triceps proximally and get a very nice approach to the entire distal humerus. And what this allows for is very easy repair of the triceps with the extensor mechanism and restoration of the triceps function. And then once we flex the elbow after we have reflected the triceps, we get a fantastic fantastic exposure without having to perform an Olecranon osteotomy. These are some cadaver dissections to show how the triceps and calcaneus flap is performed, the trap approach. You can see that the entire triceps can be reflected, and we have a very nice approach to the distal humerus. The triceps is again reattached with these different techniques. The most common one is the crisscross drill holes along with number 5 or number 2 non-absorbable braided sutures, and we begin early range of movement. So the treatment guidelines, again, just to recapitulate, is to get a maximum fixation of the distal fragment. You compress at the fracture level, and then consider shortening of the humerus at times. Early range of motion without particular fixation should be good enough to allow early range of movement. And then either use a parallel or a 90-90 construct to get your fixation. So the compression that we were referring to is at the thin plate at the Olecranon fossa, and that allows for a stable fixation. The repair of the articular surface begins with the anterior aspect, which is very critical to reconstruct to restore the function. The stability requires a medial trochlea to be reconstructed, and this has been studied in several biomechanical studies. And you may use provisional fixation initially, and that can be progressed to using screws, either headless compression screws or cancellous screws to reconstruct. So provisional plate fixation can be used with pre-contoured plates, and you can use either pre-contoured or reconstructive plates that can be countered to your fracture reconstruction. This is again a very important paper that was published by Sean O'Driscoll from Mayo Clinic, wherein he came up with these so-called 7 commandments for fixation of distal humerus fracture. Again, I'm sure that everyone must be aware of this. First and foremost, every screw should pass through a plate. Each screw should engage a fragment on the opposite side and place as many screws as possible in the distal fragment. And the length of the screw should be as long as possible. And these screws should engage as many articular fragments as possible. And they should interdigitate distally, and the plate should be applied with compression at the supracondylar level. And this is how the fixation should look like in theory. And these are the 7 commandments. If we stick to these, we are almost certain to get good outcomes. So the commandments, if they're followed, and then to add to that bone grafting wherever necessary, and then stable Olecranon fixation or early rehabilitation will give you good outcomes. We cannot overemphasize the need to assess intraoperative movement. Look for any impingement between the Olecranon or the coronoid. Remove any excessive Olecranon tip if required, and then record the movement as a baseline for your treatment. The AO classification for these fractures, whether there's a medial epicondylar fracture, these are the recommendations. If it is undisplaced, immobilization for about 2 weeks. If it's displaced, you could perform an open reduction, internal fixation, and take care of the ulnar nerve. Lateral epicondylar fractures are very rare. These are extraarticular intracapsular fractures, often seen in children more than in adults. And then this is the kind of fracture in the A2 classification. The A3 classification, the usual treatment is open reduction internal fixation in younger patients and percutaneous wires in the elderly. So these are the treatment guidelines. Very quickly, we'll just go through them so that you understand what kind of recommendations are available in literature. For the B1, B2 fractures, we use the Milch classification. And for these fractures, again, you may use screws and plates as required. The B3 is the anterior fracture of the capitulum and the trochlea. And here, again, depending upon the extent of the involvement, you would use either an anterior approach or a lateral approach, or even a posterior approach. We'll see the anterior approach in a little bit. The C1 fracture, again, is a comminuted and a complex fracture. These are best treated by bicolumnar fixation, and stability can be achieved with either a 90-90 or a parallel plate kind of a fixation. The blood supply also has to be taken into consideration. There is an avascular zone between the columns, and fractures in these areas can be problematic. But suffice it to say that we need to have good X-rays, get CT scans, watch out for fracture lines that separate the medial trochlea from the medial column. The ulnar nerve is often a point of discussion whether we should transpose it or not. The usual recommendations are, if there is going to be heavy, bulky medial hardware, it's always best to transpose the ulnar nerve. Here's a case in point. You can see that there is something going on here. This was a non-union of the capitulum in a pediatric age group patient. This is just to show you the anterior approach, wherein we create two windows by protecting the posterior interosseous nerve as well as the lateral cutaneous antebrachial nerve, and you get a very direct end-on approach. And then you can put your screws in a manner that is completely perpendicular to the fracture site and get good fixation and good reconstruction with these kind of fractures that present in the shear fractures for that matter. Again, another case where there was a non-union or a malunion, and we had to do an osteotomy. And again, corrective osteotomy with fixation can give good outcomes in these patients as well. This is just to kind of highlight a new kind of a novelty nuance in the approach, is the anterior approach to the ulna, especially for shear fractures. The results of distal humerus fractures have again been described in literature. Again, the studies are out there for you to read. I won't belabor too much on this, but the common complications that we see are, most common complications that we see are failure of fixation and non-unions in some, and ulnar nerve palsy in quite a few patients. But contractures and infections also are common complications that we need to watch out for. Heterotrophic ossification with any elbow injury is an ever looming problem. But if proper soft tissue dissection and techniques are observed, then this may not be a reality. Timely surgery, passive range of motion, no manipulation and forced range of movement is very important. And you should always be very wary of the triceps mechanism, which needs to be preserved, especially if you're doing an osteotomy or the trap approach, and get good outcomes. So that, thank you very much. This was mostly a theoretical talk to introduce distal humerus fractures. And I thank you for the opportunity. Thank you, Ashish.
Thank you very much, Abhijit. Thank you very much. Very elaborate and highlighting all the pertinent points, so I think it was a good starter for this interesting topic. And we call Dr. Dipti Narayan Reddy for his talk on the complex distal humeral fracture. Now that we know how the distal humeral fractures pose a challenge to us and how we approach them, now let us look at managing these complex distal humeral fractures. Welcome.
Thank you very much, Ashish. Can you hear me?
Yes, sir. We can hear you, sir.
Yeah. And Abhijit, good to see you in scrubs on a Sunday evening.
In Jaipur.
In Jaipur, that too.
Yeah.
Right. A very complex injury, as Abhijit had just mentioned. But actually, the more I do them, I feel that the outcomes are much better when I do a proper fixation in these injuries, which I used to be very skeptical about in the past, the more I do them, I think actually they give very good outcomes if you do the surgery properly and put the fragments back. Like with anything else in orthopedics, if the articular surfaces are well aligned and restored and give stability and mobilize them early, you get good results. So what I'm going to show you is a series of various patterns of fractures you can get in distal humerus. So principles, as we said, articular reconstruction, subchondral strut support, that's where the Shonda-Driscoll's distal screw crossover comes in. It comes in as a subchondral support, and that protects the articular surface from collapse when there is mobilization of the elbow. Struts to be fixed to the columns, so that's the reason you have 2 plates on both sides to have these columns support that subchondral struts. Sean O'Driscoll was very clear that we shouldn't put any metalwork outside the plate, but it can be done if the fragments are outside our scope of our fixation devices. But fixation should be strong enough to mobilize early. So check your mobility on table. So restoring those columns and the subchondral strut is what we are looking for in this particular fracture pattern. What are the patterns you see? There are various types of patterns. You can get a T-shaped fracture with a break in the trochlea. You can see both the columns broken, or you can get a completely articular surface fracture with lots of fracture fragments in the articular surface. The only problem with the distal humerus, if you see on the anatomy, the model, is that most of the articular surface is anterior, and we approach this bone posteriorly. And the olecranon is often stopping you from seeing what you are actually reducing. So the approach will depend on how much you can really see and how confident you are in getting your articular surface, which is very well reduced with a less than a millimeter step in it. This is a unicondylar fracture dislocation of the humerus with elbow dislocation too. And this is a very interesting combination of injuries, which are not many described in the literature. This is a medial column fracture with a dislocation of the elbow. So recognizing the pattern is important, and what approach you use depends on the type of fracture. If it is a type 1 extra-articular fracture, you don't need to do an osteotomy. You can do it through a paratriceps approach, very minimal dissection. So we can mobilize this patient early with no problems of the osteotomy. But if you have a predominantly intra-articular fracture, you need to see the olecranon. You need to do an osteotomy of the olecranon. This study was by my boss, whom I work with. My fellowship was David. And David looked at the articular surface, you can see, without an osteotomy and with an osteotomy. And they noticed that if you do an osteotomy, you can see 80% of the articular surface. But with a trap approach and the other approaches, you cannot see this articular surface because the olecranon is actually stopping you from seeing the trochlear part of your distal humerus. My preferred approach is to do a first paratriceps approach, move the ulnar nerve out, and you see I don't put any tapes on the ulnar nerve, and I didn't have to transpose the ulnar nerve in most of my fixations. When we do the fixation, and you've seen it through the paratriceps, if you can see a full articular alignment and a full reduction of the articular surface, then you don't need to do an osteotomy. At this stage, if you find that there is a problem with assessing the articular surface, go ahead and do an osteotomy, and then you can see the trochlear part. So this particular trochlear part of the fracture is what we concentrate on when I look at my 3D scans also. So that decides what I'm going to do approach-wise. So most common pattern is that you will see a medial fragment, a big one. Then you will see split in the capitulum. Often combination is not on the medial side, it is on the lateral side. Medial combination is more on the column, not on the articular side. That is the usual combination you will see in these injuries. So if you have a fracture like this, and if you're noticing that the trochlea is gone, there is a high likely chance that you are going to do an osteotomy. So this particular fracture, you can see this is missing. This will not be visible unless you've taken out the olecranon. So that you reduce, fix, and then you mobilize. So how do I do it? This is a paratriceps approach. So that's a straightforward P-shaped fracture. So fix the medial column first. Actually, the reduction of which fragment you go first will depend on which fragment is solid. So the solid one you fix first, then you have a template on which to work on. Then you put the comminuted part onto this one. The lateral side, make sure you see the articular surface there. Normally put a stay suture to pull the capsule away and see the articular surface. Then you pass a transcondylar wire, and you can use a joystick also to reduce the fracture well. Then you see the column is restored on the lateral side. You stabilize it with a temporary K wires. So you see lots of wires flying. Every time you put a wire on the medial side, your finger should be on the ulnar nerve, because there is a very high chance that you will wrap the nerve around the nerve, out on the wire. So that's the temporary fixation. You can see the articular alignment is very good. There is hairline reduction on the cortical side. Now you put a plate to fix it. Many a times this lateral plate does not sit perfectly. So you may have to twist it slightly to make it sit down, because if you put the cortical screw dorsal in the proximal part, the distal part lifts off. So make sure that you hold it on the distal part and mold it on the shaft side. That's the lateral column fixed. And the capitellar screws never pass the other side of the cortex, because otherwise you will be catching on the radial head. And make sure the radial head is not impinging on the plate on that part. So you'll get a full extension. It's usually about 3 millimeters above the capsular attachment. That's the medial side fixation. So I'm putting a compression screw there. You can even put it in an eccentric fashion. So you get the compression at that medial column as it's shown. Then you cross the paratriceps fascia, and the ulnar nerve is left in place. Make sure the ulnar nerve is not compromised. This is a example. You see so many fragments of bone. So you know for sure that you'll have to do an olecranon osteotomy. That's what I did. This gentleman had actually degloving of the whole of the skin behind the triceps. So he required a skin grafting for that. You see these screws are crossing over, and I've also put some wires here. These wires are subchondral wires holding these small fragments together, because you will not be able to get these fragments sitting correctly. So you need to put wires subchondrally parallel to the articular surface. This is a technique I learned from Mr. King, Graham King from Canada, which he uses this as a stacking wires to give you subchondral support. So you get good support and you can mobilize this elbow early. That's the range of motion. You can see that he had a skin grafting for the skin at the back. This is the rotational fracture, what I call a rotatory instability of the distal humerus fracture, where you have a single column fracture with a dislocation. So we need to address both the distal humerus fracture and the elbow instability in these. In this particular one, I actually used a lot of suture to tie the lateral epicondyle fragments. I reduced all the capitulum fragments back, and that lateral plate, the posterior anterior screws are holding the capitulum, like so. And you mobilize them early. And he also had a big abrasion on the hand, which took a long time because he had a keloid on that too later. But he regained full motion. Most of these injuries have this type of skin injury. So when somebody has a skin injury, don't forget to look for dislocations as well. This was a 42-year-old priest. He fell off his bike. He also had a massive abrasion on the arm. He had a medial column fracture with a dislocation of the elbow. So if you see very closely, there is even an avulsion fracture of the lateral ligamental complex from the ridge of the ulna, and that we fixed with a anchor and fixed the medial column, mobilized him early. He regained 95% of his motion. It's a very interesting injury, this one. She's a 30-year-old gynecologist who fell off a bladder, who had a sleeve fracture dislocation of the distal humerus. So both the medial condyle and the lateral epicondyle were fractured with dislocation of the elbow posteriorly. So we had to reduce them. If you notice in these injuries, the columns are intact. So you don't have to put any plates to hold the column. So what we need to do is basically repair of the ligamental complex. What we used is one screw on the fragments on the lateral side and anchors on the medial side. There's a lot of suture tape going through the medial fragments and a drill hole on the medial column here, which is used as a transosseous suture for these fragments. And there are also sutures going across here. So those sutures are not obviously visible on the X-rays. So restoring that alignment and reducing the joint, moving them early, you will get good function. She is back to working normally. Non-unions are common, especially when you don't do the first index surgery properly. You get non-unions, and they do end up with this sort of situation where again we need to reconstruct this with dual column plating. She required an Olecranon osteotomy because the fragments were maluniting, so we had to disimpact those fragments and realign them and fix it. She regained 85% of motion after her surgery. This is a 48-year-old man, fell off his bike. This is a pure articular surface fracture where you see the anterior column, the lateral column is fractured, and the trochlear fragment is actually flipped by 90 degrees. So to approach this, we should be able to see most of the articular surface. So I felt Olecranon osteotomy was the best approach. A pure anterior approach, we will not be able to do the lateral column or the medial column fixation. So a posterior approach and an Olecranon osteotomy was a better approach for this. So this is the intraoperative picture. This is what I was mentioning about these very small fragments where you cannot put screws. So you can put wires to hold them and pass them into the larger fragments. And there is this hole is where we put the headless screws. Of late, I've been using the locking screws we get in our distal humerus set for as headless screws, and actually sink the screws in so that they act as headless screws. That's the articular alignment re-established. Once that is done, then the columns are stabilized with struts going from this end to that end. So you get a good subchondral support when you start mobilizing these elbows. That's the intraoperative range of motion checked. Make sure he gets full motion. That's the post-operative image. And this is a follow-up image. And you see the capitulum has actually collapsed a bit. But interestingly, in spite of the collapse, he regained 95% of motion in his elbow, and he's happy going back to work. This collapse has not caused any functional deficit. But I see that there is some loading on the medial side, and he might develop ulnohumeral arthritis in the long run. This was a 22-year-old pregnant lady who was 8 months pregnant, who had this fracture, which was a purely articular surface fracture. Again, multiple fragments. So we did an Olecranon osteotomy, reduced all the fragments and mobilized her early. Except for final 10 degrees of extension, she regained all the motion. We removed the metalwork also for her at about 8 months' time. This is another example of a purely articular fracture. Again, Olecranon osteotomy, reconstructed. And this was the about 3 months post-operative. He also had removal of metalwork because that wires were causing a problem. And one of the wires which we put subchondrally had walked back, so we had to remove that. 62-year-old gentleman fell at home he's on hemodialysis. Interesting problem in him was that we had the AV fistula on the same side of the surgery, so we did not use a tourniquet. We did it without a tourniquet. And that's a fixation, a para triceps approach, no olecranon osteotomy because the fragments could be reduced well. That's his postoperative at 8 weeks. Another interesting injury fixed elsewhere. They fixed the lateral column, but forgot to reduce the radiocapitellar joint. So always look for radiocapitellar alignment whenever you have a lateral column fracture. So he essentially had a lateral column fracture dislocation, and the dislocation part was missed. So we had to redo the surgery to reduce the radiocapitellar joint and again stabilize the lateral column as well. And that's his 3 months postoperative flexion. Another interesting problem, badly done distal humerus fracture fixation. This is a 68-year-old lady, fractured a year ago, had a surgery, the metalwork started failing, and she had 2 incisions, both a medial one and a lateral one. And she also had distal radius fracture on the same side. That was also badly done. So that needed revising. This needed revising too. So unfortunately, the ulnar nerve was cut during the surgery, the first surgery. So when we explored it, we found this was the end of the ulnar nerve. And then we proceeded to remove all the metalwork, realign the fragments, and repaired the ulnar nerve. That's the fixation. And interestingly, she regained full motion there and also improved her ulnar nerve function. This took nearly a year to improve. 69-year-old lady, 8-month-old injury. When we looked at the CT scan, you saw multiple fragments in the articular surface. I felt it could not be reconstructed because there was only a shell of bone on the coronal sections of the CT scans. So we decided to go ahead with elbow replacement. And that's her function 3 months post elbow replacement. Elbow replacement has a role in distal humerus fracture in elderly only. Please don't put them in young, especially men, because they will require revision sooner than the low demand patients. And these patients will have restrictions of how much they can actually lift with that arm. Not more than 5 kilos at a time is what we normally recommend. So elbow replacement could be preserved only for complex, non-reconstructible elderly patients with distal humerus fracture. So if you restore anatomy, mobilize early, you regain function. Thank you.
Thank you very much, sir. Amazing collection of cases and tricky problems that you have shown there. Very interesting point you made about the Herbert screw. Instead of the Herbert screw, you've been using the locking heads, the locking screw, which is there in the set. So that's a 2mm screw, right?
Yes.
Yeah. So it's a very low profile 2mm screw, and you can sink the head inside.
Sink the head inside.
Yeah. So it's used mostly as a position screw rather than a compression screw, isn't it?
No,
I mean,
interestingly, that's what I thought. But actually, if you look at the pitch of the thread on the proximal head, where you are actually using it to lock to the plate, is smaller than the pitch on the screw distally. So it's essentially a differential pitch screw.
Right.
So you do get compression too.
You do get some compression as well.
Yes.
Excellent. Excellent. A very nice, 2 talks in succession about these distal humeral fractures, about the different concepts. And so we move on to the coronoid. And I would invite Dr. Abhijit Vaigaonkar again to talk about coronoid fractures and dealing them, especially from an upper limb and a hand surgeon's point of view. Over to you, Abhijit.
Thank you. Thank you very much. Deepti, may I request you to please...
Yeah. I'm just stopping share. Yeah. Sorry.
No, thank you. That was an excellent talk. I enjoyed it.
Yeah.
A lot of learning points from your talk. So we'll move on again with me. Bear with me, please, as I take you through this challenging and difficult aspect, which is coronoid fractures. And Coronoid fractures can be a challenge. Unfortunately, they're not very commonly talked about and discussed. And we'll try and endeavor to understand these in today's talk. So the problem with coronoid fractures is that they can be very subtle, as many of you might have seen in your own patients. And fracture subluxation will usually lead to incongruity and progress to degenerative changes, especially in the ulnohumeral joint. And what we look for is this river delta sign, wherein we need to see to be a congruent and equidistant wave on all aspects of the ulnohumeral joint. Gross elbow instability because of coronoid fracture will have a similar X-ray appearance. Look at this here now. The river delta sign is different from what we saw here. And these are subtle kind of indicators of the instability pattern. And they can be classified into type 1, type 2, and type 3. This was described by Regan and Morey in 1989. Type 1 being only the tip, type 2 being about 50% of involvement of the coronoid. And when it's more than 50%, it's a type 3 fracture based on a lateral radiograph. These fractures were also classified by Sean O'Driscoll, wherein the tip fractures were classified into two subtypes. Then he classified them as the anteromedial fragment and basal fractures, with these subtypes that have been described in his classification. And he looked at 51 consecutive coronoid fractures, and he found that type 1 accounted for 17 of the series, and they were the commonest, whereas the type 2 fractures were less common, and then there was some kind of distribution between type 3, type 4, and type 5. The anterolateral coronoid fractures are perhaps one of the most frequently encountered fractures, and these fractures involve the tip and the anterolateral aspect of the coronoid process. And what are the patterns that we encounter and how do we treat these fractures is something that we will try to see through these series. This is a schematic diagram of a type 1 or a tip fracture. These are pretty subtle fractures and may be missed very often. And they present as a posterolateral rotatory instability in chronic neglected injuries. There may be injury to the lateral collateral ligament associated with fractures of the radial head and a possibility of a medial collateral ligament. And the dilemma is what to repair in such cases. So tip fractures essentially are an elbow, kind of an elbow dislocation and should be treated as such. The coronoid tip fracture cannot be fixed and often repair is not needed. However, the guideline is to perform an evaluation under anesthesia and a fluoroscopy and then decide which way to go. The coronoid fractures can either be treated from the medial or the lateral aspect depending upon whether the radial head is fractured or not. And more often than not, we use these pull-out sutures through the base of the coronoid with non-absorbable braided sutures. We prefer to use fiber wire, and then we make these two drill holes parallel to each other, and we come out on the posterior aspect of the dorsal aspect of the ulna, and the sutures are woven through the capsule and the small fragments. And this can be done again from the medial or the lateral side, depending upon the presence of a radial head fracture. If there is a radial head fracture, we can use it to our advantage and work through the defect to repair the coronoid from the lateral side, as is seen here. So that is a fracture of the radial head, and then you expose what I'm holding in the forceps here is the capsule, and these are heavy braided sutures that are passed through the capsule, the osteocapsular attachment, and then through the base of the coronoid and brought on to the dorsal aspect. That's how it kind of can be repaired along with radial head fixation or replacement. The second subtype is basically anteromedial fracture of the coronoid, which again is a very subtle fracture and can cause very significant instability. And this now results in a pattern which is called as posterior medial rotatory instability. And again, in these cases, there may be an injury to the lateral collateral ligament. There is an antromedial coronoid fracture. There is a rupture of the medial collateral ligament. And it's usually the anterior band that is intact, but the other components of the MCL are usually damaged. So when we have antromedial fractures, what do we fix? We usually use a posterior approach. On the medial aspect, on the medial side, the coronoid is approached to the floor of the ulnar nerve. We perform an open reduction internal fixation of the coronoid with an anti-glide plate, and an ACL guide can be used to your advantage to either pass the screws or the sutures. And on the lateral side, we perform a repair of the lateral collateral ligament back to the humerus from which it's usually torn using suture anchors. So here is a case in point wherein there is an anteromedial fracture of the coronoid with a posterior medial rotatory instability of the elbow. We have used a plate to fix the coronoid along with a repair of the capsule or the pull-through sutures for such patients. The operative technique, this is a video from the American American Academy of Orthopaedic Surgeons, David Ring's video, where you can see that we go through the floor of the ulnar nerve, we protect the ulnar nerve, and then you raise the flexor pronator mass of the sublime tubercle so as to approach the ulna in a manner wherein you can put your plate or screws as required very effectively. This gives you a very nice approach to the entire proximal ulna and the coronoid. That's the sublime tubercle that is being put into view. That is the coronoid process again, and you can see the movement in the joint, and the joint is laid open, and then you also have the sublime tubercle right there. So again, a case of antromedial coronoid fracture. This is a CT reconstruction. What we find at surgery is that there is an avulsion of the medial collateral ligament with a type 3 Mason fracture of the radial head and also an LCL avulsion. So what did we do? On the medial side, we repaired the coronoid fracture with suture passing through the capsule. We also did a reconstruction of the medial collateral ligament with a palmaris longus graft. On the lateral side, radial head replacement with repair of the lateral collateral ligament. Again, an anterolateral fracture of the coronoid in a 59-year-old right-hand dominant female. You can see the radial head fracture along with the coronoid fracture. On the anterior aspect, we fix the coronoid. On the lateral side, radial head replacement with LUCL repair and extensor tendon reefing. On the medial side, we repaired the medial collateral ligament just like so. And at 2.5 years post-op, she had about a 20 degrees extension lag with full flexion. Basal fractures of the coronoid, again, are very difficult to treat because the fracture may be comminuted and difficult to approach. Usually, this can be fixed with either headless compression screws or cannulated screws, and repair can be done in a manner from the medial aspect as was shown in the video that we just saw. So there are two ways that we can approach the coronoid. One is the over-the-top approach and the flexor pronator split approach as was seen earlier on. This is again a patient with a closed elbow injury. These are the CT scans and the radiographs. You can see a very large fracture and comminuted fracture of the coronoid, and this rendered the elbow very unstable. We use the Olecranon fracture to our advantage, and then we fixed it and repaired the collateral ligaments as well. There are newer techniques of coronoid fracture fixation. I unfortunately don't have any experience with this, but just for the sake of completion, arthroscopic assisted fracture of coronoid assisted treatment can also be done. And this is a paper by Scott Steinman and Julie Adams. They reported on 7 patients wherein they had 4 type 2 and 3 type 3 fractures, and arthroscopy assisted fixation using screws, stainment pins, or arthroscopic debridement and plate and screw after arthroscopic reduction was also performed. The results again are similar to open surgery with good outcomes in 5 out of 6 patients in their series. There are certain pitfalls. One is association of an Olegron fracture along with a subtle coronoid fracture. We need to be very careful. Here's a case in point. That's a fracture that can be seen. And unfortunately here, this kind of a screw was used, which was not enough to catch that fragment. And over a period of time, that fragment was had a loss of reduction, and again, the instability was seen in this patient. So we need to be careful where and how to put the screws using anti-glide plates, and that will help you in avoiding complications. External fixation can also be used in very severely unstable elbows where there is a lot of comminution. We usually reduce and secure all bony and ligament injuries. If intact but fragile, we consider either a splint or a sling to limit motion. But compass hinge fixators can come to your rescue, especially if the construct is unstable, and to allow for movement while the soft tissue is healing. So in summary, do not misidentify the antromedal fracture as a tip fracture, because this is the basic tenet of difference between a posterior medial and a posterior lateral rotatory instability. When there is an elbow dislocation with no radial head fracture, look closely for a coronoid fracture. Have a high degree of suspicion. In such cases, you may use a medial approach, either a flexopronator split or a over-the-top approach to expose the sublime tubercle, reduce and fix with an anti-glide plate or screws as required. The most common complication that we see following missed coronoid fractures is instability and stiffness, resulting in post-traumatic arthrosis. So we need to be on the lookout for such patients. So with that, I thank you again for your patient listening for a topic that is really challenging and difficult to manage. Thank you very much.
Thank you very much, Abhijit. Thank you so much. It was quite comprehensive, and those videos, they were very good. Yeah. Thank you very much. I'll see if there are any questions that come up on the chat box, but so far it's been quiet. I think it's been disabled here. I would like to invite the AO Trauma India Chief, Dr. Dhaval Desai, to talk to us, and he has got a very interesting case, which is
Ashish.
Yes, sir.
Am I the last one?
Yes, sir.
Okay. Good.
You'll have the last word, sir.
No. So I'm just going to. Is that visible now?
Yes, sir, it's visible, sir.
So I'm just going to quickly run through, since we have a panel of some great experts. I'm just going to quickly run through two fracture radial head with dislocation cases that I've seen and managed, and let's see whether anything you could have done different. Okay. So let's start with, and we got a very eminent planner around here, right?
Absolutely.
Right. So this was a young male who had a fracture dislocation of his elbow. This was his pros reduction X-ray, and that's his CT. So, question open to the house. What would you do, or how would you do?
I think we have Dr. Srinivas Kasha, Dr. Abhijit, Dr. Dikti is here, Dr. Praveen Rao, and Dr. Moorthy is as well here.
Anyone?
So this is Dr. Abhijit. What I see is it's probably a case of cerebral triad.
Right.
A radial head fracture with a coronal fracture type 1 and a lateral injury, collateral injury, for which a close reduction has been done.
Exactly, yeah.
So we follow the protocol. Yeah. If the radial head it doesn't seem salvageable.
Half of it is
So
out, half
probably
of it
will
is in.
replace. Yeah,
Okay.
but majority of it is out. So probably
Right.
modular
Mhm.
prosthesis uncemented would be a choice. Then repair the coronoid and repair the lateral LUCM.
So, Dr. Abhijit, my question, can I question you? Yeah.
Yeah.
Dr. Abhijit, can I question? So,
Yes, sir.
outcomes
Yes.
of radial head replacement, would you think the patient would get a kind of a reasonably good range of movement that could be?
Yes.
What do you think? What's your experience? Others, Abhijit or anybody else?
Yes, sir. Probably in a well-done surgery, the outcomes are good. They definitely have a functional range of movement, and importantly, the elbow is stable.
By functional, you mean like 90-degree flexion and that sort of a situation?
Yeah, probably they even get more, sir. That was in the initial part. Now 120, 130 degrees, starting from either 5 or 10 degree of flexion deformity, with a further flexion possible up to 120 degree. That's the range of movement one can expect in this patient, and a good degree of pronosupination.
Sure, yeah. So anybody for fixing this radial head? Abhijit?
I would like to fix this, sir. So Dr. Srinivas.
Srinivas.
Here.
Okay.
Yeah.
And what would you like? Yes, Ashish.
Yeah, I think Srinivas, you're very slow.
I would like to this track.
Yes, somebody has, who's there with is that Dr.
Diptinandan here, sir.
Yes, sir.
Yeah.
What's up?
So this is a classic, presentation you would get
It is
in this injury.
reconstructable, then only the last to repair.
Sorry, Srinivas, carry on. We couldn't hear you well.
Yes, the network was down. I think Srinivas, we lost your voice in between. So you can just repeat what you said. I mean, we got the gist of it that you're going to fix it.
Yes, Srinivas.
I think it's frozen again.
Okay. Can I continue?
Yes, sir. Yes, sir.
Yeah. So this is a classic case you would normally get with this sort of injury. And first thing I would do is those fragments of radial head, I would take it out, put it on the table. I would first fix the coronoid. The way I do my coronoids are mostly a trans-ulnar tunnel, two tunnels going into the bed of the coronoid fracture. We pass the ethibond suture, take a bite through the capsule around the coronoid, the tip fragment, and pull it down onto the ulna. So that gives you the anterior-posterior stability for the elbow. The next thing you need to do is
can I interrupt Dr. Deepti?
Yeah.
So they're pretty stable post-reduction kind of. So, I mean, there is
no
instability of the elbow. So, yes.
See, if you
why
are
do you
there
want to do anything
and
to
your
the
radial head is off and the coronoid tip is broken, it is better to get that stability as well. And next thing I'll do is reconstruct the radial head, put it back, and normally use a tripod fixation for this. I use a tripod fixation for the radial head. I first fix the two fragments together, then fix the radial head onto the shaft, and these patients get early mobilization. There are no plasters.
Right.
Okay. Is there an option for a delayed excision of radial head in this? Because the elbow is stable.
Yes. So this is a question which you keep asking, because when you have an injury like this, we are not sure if the medial collateral is intact or not. One. So there is a chance of instability. So the problem here is the instability. Yes, you can remove the radial head if he has stability with the elbow being able to extend beyond 40 degrees. That means if the elbow remains stable at 40 degrees, it's a stable injury. If it is unstable at 40 degrees, it's an unstable injury. And if the range of motion in
the elbow was stable at 40 degrees, it may add to that. So when I was checked under CM, it was stable.
Yeah, that's fine. So if they are able to hold it and you have full range of motion, it can be managed non-operatively.
Dr. Rao?
So I wanted to ask you something, Dr. Dipti.
Yes.
When you mentioned about the pull-out stitches, would you use something like an ACL jig or so to direct both your...
No, nothing. I use my finger and my drill. That's it. So yes, ACL jig is a good option. I agree. but I tend to use it because the space there is cramped. It's not easy to get space in there. So,
and then you would pull out on the dorsal aspect of the ulna, right?
Correct.
Okay. The other thing was, I mean, you're checking this stability of the elbow. So you would check this after fixation of the radial head, right?
No. In fact, if I'm there, because once you fix your radial head, your access to the coronoid is lost.
It's gone, yeah.
So first get your coronoid bits in, get your sutures in, then you fix your radial head, then you tie this. Then you also repair the lateral collateral.
Yeah.
That's the sequence of my fixation in most of these cases.
That's what I was asking. I mean, when you mentioned that the elbow is stable at 40 degrees.
That stability point of view, which, because he said, why not do a non-operative? That's the answer for that question.
Yeah.
Okay. Anybody has anything to add?
Yeah, Double Sub, can I come in?
Yes, Praveen. Yes, I was waiting for you, Praveen bhai. Yes.
Okay. So the first question about your radial head processes, I've not done many, but I think radial head processes is in my hands. If the radial head is more than 3 fragments, if the neck is fractured, I think that is an indication for the prosthesis. But if the radial head is in 2 or 3 large fragments, most of the times it gets reconstructed. And as Dr. Deepti said, the tripod kind of fixation is what I would use in this. I feel radial head prosthesis in the long term is probably not as good as the other prosthesis. It is probably a stopgap kind of arrangement to maintain the length of your fixation or your ulna, for that matter. In this case, I would take out the radial heads. I'll put it on my back table, see how well I can actually reconstruct it. At the same time, through the same approach, I could probably see the coronoid. I'll fix it through some suture anchors, and then probably put the radial head back. That would be my approach.
So overall, the results of radial head are not very happy, is it? In your book?
Yes.
And that's what I think. Somehow, the long run, they don't seem to be happy bunnies. They are more stiff and more. Yes, Dr. Deep.
Doubles up. I'll just I'll give you a background to the radial head thing, because I trained with David Stanley in Northern Jungle, and we looked at our radial heads over a 2-year period, and 50% of the radial heads had to be taken out at 2 years because of forearm pain. And this is, I'm talking about, this study was in 2009, 2008, 2010, that period. So we were doing a lot of initially to give the stability, but many a times is a spacer, as Dr. Praveen has mentioned. It's a spacer to give you stability till your scarring of the elbow happens, and then you can take out the radial head if it causes a problem. The biggest problem I have when I return to India is this, that the prostheses we have in India are not designed as proper radial heads. And that's a statement I'm giving after seeing all the components we have available. Unfortunately, there is 1 or 2 designs which have come into the market, which were actually discarded from the Western market and has come into our market. And some of them were just designed as a simple mushroom and put in. And I'll tell you, Sean O'Driscoll has put in a lot of effort in designing his radial head, and he was talking about press fit, and all these things. We were discussing about all this 10 years ago. And 10 years ago, we were not having a good solution to it. Only one which was working was the one which Graham King showed. And the results outcome-wise, if you look in the literature, it is the bipolar radial head which have a better outcomes than the ones we have available here.
Can I ask a question?
Anyway, so yes, Ashish.
I mean, I appreciate that, a lot of heads from Dr. David Stanley's study were taken out, but how many of the panelists have actually gone down and taken out the radial heads that you have put in? I mean, because I sort of agree with Abhijit that sometimes these radial heads do surprise us, or they do well. I mean, I haven't had as much experience as most of you have. But have you had the experience to take out your own radial head? I mean,
no, I'll give you a simple logic to this. I'm giving you a very anatomical logic to this. Radial head is not a round bone. It is an elliptical bone. You are putting a round component inside. And if you look at the axis of how the neck is always at an axis. So it doesn't rotate in a circle. It rotates in an ellipse. So that is the reason why it's very difficult to get an anatomical replacement for that particular component. So they have designed different ones with the different shapes and other things. And also the variation in the sizes and the depths are so much that we cannot reproduce them, technically on table. That is the problem. And when you put a metal against a bone or a cartilage in any part of the body, in a young person, and most of these are in youngsters who are in 20 and 30, what will happen?
It will lead to some osteolysis, or it will lead to some chondrolysis.
Capitellar erosion, or it will cause forearm type pain. So
lovely. Thank you, everybody. So we move ahead. So we kind of choose for the waiting approach for him. We said we'll have a delayed. We gave him all the options, and then we thought let's wait before we go in. And I was also contemplating about spacer at a delayed this thing. So remove and see how this feels. We are progressing. Why is it not moving? Okay. So that was his at about there was a COVID issue. It was last year, so he was also not very keen to get a surgery done. Somewhere along the line, I was just contemplating that what we will. So with a stable elbow, the half the radial head out, but the elbow stable. I was just wondering what will I offer from outcome vis-a-vis function. So at about 6 weeks, the elbow was pretty stable, range of movement reasonable. The half radial head was not obstructing movement by any means. Okay. So we waited, and then he gave him the option, and he chose to wait with us. Okay, so this is him at about 6 months. Okay. He had a little restriction of pronation initially down there. Okay. So that's his range of movement somewhere at 6 months. Okay. That's him at about 9 months, 15 months now, finally, that he came just recently. He's able to drive a bike. He's able to do all his work in the office, computers. And that's him at, it's at about 3 months last that I saw him. Comments open for discussion.
Yes, sir. This is a classic example of why we should not do a radial head excision, which I'm totally against. And, this is the reason why he has a biological spacer, which is formed with bone there and some scarring there. And that is better than, whatever surgical excision and things we do. And I would not replace it. And I don't think we should consider radial head as a replacement of a joint. It is more of a spacer. So this is a very good example of that. And I have treated a lot of these radial head fractures without surgery and just mobilization. One tip, sir, is that please do not put plasters on radial head fractures. Mobilize them early. Mobilize them early. The active flexion of the elbow gives the stability of the elbow. So active flexion is what we should recommend. And if you have a unstable situation, avoid extension beyond 40, but flex actively, and never send them for physio is my mantra.
Not gone to physio.
That is why the result is good.
He was under absolute supervised follow-up. He was not, I said, because the elbow was stable, I thought this track will go, otherwise I would not have. So we were just kind of a conscious decision with the patient. And I think in the middle, the COVID helped. Okay. Ashish, how are we doing on time? You finished?
No, I mean, we can go on.
One more case?
Yeah, we have overshot.
One quick case.
We can do that, yeah.
One quick case. So another one.
Sir, may I make a quick
this was a school teacher. Yes, please.
Yes, so probably even with the conservative line of treatment, the prognosis and terrible triad of the elbow.
Yes. Yeah, I just feel sometimes
properly selected cases.
Yes, I think we sometimes we are too aggressive, I feel.
Yeah.
With the current sort of, webinar knowledges and but we are sometimes. Okay, so this was a school teacher, 45-year-old. That's the injury. That's her fracture. Yes. Srinivas, what would you do? I think she wasn't dislocated, as I remember. And she came for a second opinion, not seeing her primary. The other one was I was seeing it from day one.
Yeah. Sir, am I audible now?
Yes, you are.
Yeah.
Yeah. It's more or less like last case. You got a coronoid fracture here, and
Yes.
radial head is completely intact. In the sense, it's only neck fracture.
It's a live spacer.
Yeah. So nice spacer to have it. So I would like to fix it. And same approach. Go in and then first attempt coronoid, if I can pass through this particular approach, and then radial head fixation followed by checking the stability on the medial side. Then if it is opening on the medial side, I'll open medially and then repair medial collateral. That's the sequence.
Was the combination of the neck sizable, right?
Yes.
You will need to do something more than just a plate in this case, right? Probably. Otherwise, you'll end up with a shortened neck with not, the stable situation not being there. So would you have to then, if you fix, graft this or, do something like that? I'm just wondering.
Yeah. So looks like if I feel there is a big gap, I would take some graft from the Olecranon itself and then fill it up there.
Dr. Rao?
Yes, sir. These are the fractures I'm afraid of. Comminuted neck. I don't seem to get these things right. The rotation is always a problem. You need to put a graft. You need a little longer plate. And I've struggled. I've done a couple of them, and I've always struggled with this. I think as of if I get a good fixation, that's okay. But otherwise, I would probably go ahead and put in a prosthesis for this after repairing your conoid.
So are there processes that also take care of the radial neck that's lost length? Is that no?
Yeah, nowadays you have a couple of processes. I think one which comes from biotech, if I'm not wrong, which has different lengths of your
okay, the new one from biotech. Okay, Dr. Dipti, any different thoughts on this?
Yes, as Dr. Praveen mentioned, these are the tricky ones. They look very simple. In fact, sometimes I feel we should just leave them non-operative. Even if they go for
you think
a
so?
non-union there, I don't have a problem. So.
Okay. Ashish, anything, your thoughts on this?
So I think I will agree that, this a simple plate is quite tricky. So I would have a low threshold to use a prosthesis here. And as Dr. Dipti said, we have a very limited range. One which is made by that SYS. Actually, it comes from Ahmedabad, and one which is available locally.
Ahmedabad guy, yeah, this guy, biotech.
Biotech, yeah. So those are the only processes that we get. But we find that the stump of that of the stem of the biotech prosthesis is quite a stress riser kind of a thing. If you don't get in correctly, we can't sort of get. But otherwise, I would agree with Dr. Srinivas.
And Kasha, do you have any preference on the plates? That because some of the designs I have seen, they are not very good anatomically designed plates. I think again the cost becomes a very imperative because you'll have to use a proper plate. Is that what your experience is?
Yes, sir. I always use synthesis plate. So with an oblique screw, which
oblique screw is one which is that is probably Okay, so again with her, she had a stable elbow. She wasn't too keen for getting surgery done. So as Dr. Deepthi said, we will wait and see what happens. We could always go back and do something for her. So that was her at about 3 months. That's her movement. Again, a very cooperative patient. That's her at about 6 months with kind of pseudo-arthrosis, not fully united, one would say, but extra kind of union happening at one cortex. Okay, and that's her range of movement. And then that's her at about 12 months, I think. Okay. She's been happy with the outcome. She has followed up, not in the last 6 months, but on sending patients with that reference. So I'm very sure she's happy. Again, these are again not very easy decision-making situations. I think these are not that, I'm not saying I'm saying that this will work every time, but I think sometimes holding back and seeing might be an option that is worth thinking, especially with challenges where I don't think you'll get this kind of a function with fixing this. Kasha, would you think you would get a function like this with radial head plating?
That's fantastic function, sir. And COVID must have helped you.
Absolutely.
In
I think
taking
in
easy
COVID
decisions.
times you've learned a few good.
But but with coronoid fracture, I would like to fix it. When
So
it is
I think the decision probably comes within whether the elbow stability is on your side or not. I think if the elbow is stable, you have a time to play. If it's not, then you can't.
Yeah.
Completely.
On that.
Yeah.
On that.
I think you got away because the elbow was stable in both the cases. That is probably, yeah.
That's what I'm trying to say also. If they weren't stable,
Exactly.
I would have to have been committed to do something.
And I'm extremely sorry. I missed what Dr. Deepti said. So could I just hear it? I'm so sorry. I couldn't. He wanted to plate it and something.
No, he said conserve this case.
Oh, he said conserve. Okay.
Yeah.
All right.
Okay. Thank you, everybody.
So may I make a quick comment?
Yeah,
Probably so the need of the hour is to have a radial head prosthesis which is of a modular variety, and we should probably go for a stem which is uncemented and which should not osteo-integrate. We should not try to extrapolate the principles of NEM hip arthroplasty into radial head arthroplasty. Where the principles are altogether different.
Yes, that is where Sean O'Driscoll's initial processes with Acumed had actually had a completely different approach. That had a curved stem which would fit into that, and it had a HOA coating, and he would put big ones in. And he said the reason for failure is you're putting smaller ones in. The integration should be better. But we realized later that is probably the reason why they don't do well. We don't know.
Good. I think there were very interesting cases by the rest of you, very challenging trauma cases that were fixed.
Excellent. It was a wonderful session, sir. Wonderful session. So I'll just take a quick opportunity before we wind up this session to.
So while we are in, just want to ask you about that in the elbow. In the last year before, I've seen about 3 spontaneous triceps rupture. Anybody has seen and kind of experiences or thoughts on that?
So I have come across 2 cases of spontaneous triceps rupture. Both these patients were into bodybuilding, and they were taking a huge amount of steroids. And so from that group, 2 of them had a triceps rupture, and the other 2, they came for a TA rupture.
Okay.
Yeah, so I probably concluded that it was a trival injury which was missed, which was neglected, and which progressed into a complete rupture.
The other thing is they're also quite can be neglected, means they're not very easy to pick up. Yes. Because if you don't do prone extension, sometimes you'll just miss the injury. So that was one of them was missed because it wasn't evaluated, I thought. So it was, you could flex and therefore not everything, there's no this thing, but the strength and not a prone extension is the one that gives you that.
Yes. So
one more point. Gravity helps in extension, that is missed.
So today's seminar proved a point that terrible triad, the injuries around the elbow, whether we treat them surgically or conservatively, the prognosis is no longer terrible.
It is not really terrible.
Yeah. So as
the caveat there is that you should have a stable elbow.
Yeah.
when you have a stable elbow.
And a concentric elbow.
Yeah. I think the understanding is increasing and has increased with this circle of Cori concepts and the sequence of ruptures. That's the reason why more and more people are aware and they address to it. Anyway, I think we have had a very wonderful session and a very interactive session. I'm sure this will garner a lot of views and people will get benefited from this webinar. I would like to thank TOSA for very actively participating along with the West Zone of the IOA. Me and Dr. Abhijit would like to warmly welcome you, every one of you, to Mumbai in December on the New Year's, where we are going to have the 57th annual meeting of the Bombay Orthopaedic Society, the WIROC. And here's just a welcome message for all of you before I hand over to Dr. Srinivas. Dr. Rajesh Gandhi, who is the president of the Bombay Orthopaedic Society, me and Dr. Abhijit would like to, welcome everyone who is watching, all the delegates, and of course, the esteemed members from TOSA. And we would send an official invite to all of you. And I hope, Srinivas, we get to spend the New Year's in Mumbai with family. Welcome you. And over to you, Dr. Srinivas, for the concluding remarks.
So, thank you very much, Abhijit. So, on behalf of TOSA, I would like to thank all the faculty. It was a wonderful academic feast today, starting from Dr. Prathap sir, and then Dr. Praveen Rao, Dr. Jignesh Pandya, Dr. Deeptinandan sir, and Dr. Abhijit. And lastly, a very interactive session by Dr. Dhaval Desai sir. And I must thank Dr. Abhijit Kale and Dr. Ashish, my friend, for coordinating the event. And I should thank Dr. GVS Moorthy sir, our president, who is all the time encouraging all academic events. And of course, West Zone IOA. President Dr. Ajit Shinde sir, Dr. Vikas Jain sir, Dr. Shivanand Pandekar sir, and of course our beloved IOA President Ramesh Sen sir, Dr. Atul Srivastava, President-elect, Dr. Ram Chedda, Vice President IOA, and Dr. Naveen Thakkar, who is Secretary IOA and West Zone. So I must also thank the Ortho TV, Dr. Bizlani and Dr. Ashok Sham. And with this, I can conclude. Thank you, one and all, for watching and participating in this academic feast.
Thank you.
Thank you.